In this lecture we're going to look at ultrasound imaging of the breast. As you're probably all aware from the media, radio ads, television ads, breast cancer is a very common malignancy, and I'm quite sure all of us, if we don't have an immediate family member, we certainly know neighbours or friends who have been affected by breast cancer. So it is extremely common, and there is a lot of money for research for breast cancer and for breast awareness out there for both females and for males, because males can get breast cancer as well as females. Naturally, like with any cancer, the earlier we pick up and find a cancer, the better the prognosis for the patient, because it hasn't invaded as much tissue, and the likelihood of it spreading to multiple areas is decreased if we can pick it up earlier. And that's really the whole point of really doing mammography, is to pick up these cancers when they're early, before they really, we want to pick them up before we can feel a palpable lump. For this reason, even to date, even though the technology of ultrasound has greatly improved, today mammography still remains the gold standard in screening of the breast, so that in the screening we're picking up tumours when they're at the small calcification stage. As I said before, they actually form a palpable lump. So in the future that could change, possibly with technology, but certainly today that's still very much the case. So ultrasound does have a role, certainly in younger people, and also in people where we're seeing something, say on the mammogram, and we're not sure whether it's solid or cystic. Then an ultrasound will define that for us. In a patient who's pregnant or breastfeeding, we may opt to look at the breast with ultrasound rather than irradiating the person with a mammogram. So there are instances where we'll just do an ultrasound on the breast, but in the majority of cases the ultrasound will follow a mammogram. It's very important, and what we're going to talk about in this lecture is we're going to talk about benign and malignant characteristics. And if we find a lesion, we look at every lesion and we go, does this lesion look benign or does it look malignant? And often if we think it's benign, we will follow it up in about 6 months' time to make sure that it hasn't changed or hasn't grown, just to be doubly sure that it's a benign lesion and nothing to worry about. If in any doubt, if there's some characteristics that mean it could be malignant, the best option is to biopsy it, so to actually stick a needle in and get some cells out and be 100% sure of the cells and what's going on within the lump. Now these biopsies we can do under ultrasound guidance, so we can assist as the radiologist puts the needle into the breast to make sure, watching with the ultrasound, that the needle goes into the actual area or lump that we're interested in, because it's no good if they just end up in a bit of normal tissue beside the lump. So we can confirm by watching with the ultrasound that the needle has actually gone into the lump. So why might a person have an ultrasound? And the most common reason is for lumps in breasts. So females are very well educated now to be checking their breasts once a month. They'll get to know what their breasts feel like, what normal lumps they normally have. But if a new lump appears, then generally speaking, that's something we generally worry about, and so you can come and have an ultrasound. And the great thing about ultrasound, as opposed to mammography when it comes to lumps, is you can put your finger on the lump and put the transducer right over the top, so you can actually image what the patient is feeling. Another common reason is pain. The breasts generally shouldn't be painful. They can be painful at different times of the female's menstrual cycle, but again, if that pain is out of normal, it's not what normally happens for the person, then we need to have a look at the breasts and see what's going on. Discharge from the nipple is very common. Often the discharge is a straw coloured, milky coloured discharge, which is perfectly normal. However, sometimes these discharges can get black, they can be bloody discharges, or they can have a greeny colour to them. Again, it may be perfectly normal, but any discharge from the breast is worth consulting with the doctor, and often will result in a mammogram plus or minus an ultrasound. The other big one is this family history of breast cancer, and we now know there is a gene that can be passed on within families, and it can mean that if the genetic testing shows that it's in the family, that people have this gene, and therefore we need to monitor them very carefully. And often we do questionnaires and we check, is there any family history of breast cancer? Also with that gene, it's linked to ovarian cancer as well, so that's another thing that we need to check, is breast and ovarian cancer. So some of these patients decide to have radical treatment and have their breasts and ovaries removed. Others will have regular mammograms and ultrasounds to monitor the breasts. But it's always a good idea, if there is any family of history of breast cancer, that females within the family have their breasts routinely checked. So the next one is the routine checking on the breasts. So usually I think they say at about 40, females generally recommend to go and have an initial baseline mammogram and breast check, and then check it up them regularly from then on in. As we've talked about, post a mammogram, particularly if they've seen something on the mammogram that they're not sure whether it's solid or cystic, or want to look at it further. Biopsy guidance to show the needles going in to the area of interest, so we know we're getting cells from the area. The other common thing is breast implants, or they often refer to it as breast augmentation, will be written on the referral. So they used to be made of silicone. They're now made of saline, and a lot of the old silicone ones have thankfully been replaced because they were rather nasty. We need to, on ultrasound, assess then the breast tissue, and then also the implant, because sometimes the implants can rupture within themselves or out into the breast tissue. They can go hard in spots and move and things like that. So if the patient has had implants, we need to assess both the implant and the breast tissue as well. And the final one on the list is breast trauma. This is particularly common in car accidents with the seat belt going across the female's chest. Often the breast can get damaged in car accidents, so you can end up with hematomas and things like that in the breast. Sometimes they need draining. Obviously over time the body will resolve them. I also had a patient once who was starting a lawnmower, and it was an old pull string lawnmower, and when she's pulled the string on the lawnmower, she actually tore her pec muscle behind the breast, but she didn't realise that that's what she'd done. But later on, her breast was all swollen and big and swollen and sore and terrible, so she came in for a breast ultrasound and was very relieved to know that she'd actually torn her pec muscle in starting the lawnmower. Alright, now the breasts themselves are actually referred to as modified sweat glands, but instead of obviously producing sweat, they produce milk. So they're there to feed babies, and that's once a female gets pregnant, the breasts change and start producing the milk. They actually lie anterior to two muscles, the pectoralis major and the serratus anterior muscle, but just to know that when we're imaging, we need to see all the way down to those muscles, so then we know what we're looking at, all of the breast tissue. They're really mostly we call them separated into two types of tissue. We call them glandular tissue and fatty tissue, or adipose tissue. So the glandular tissue, it has the lobes and the ducts and everything that's needed to produce the milk, and the rest of the breast is just made up of fat. And so it's this glandular tissue, this functional part of the tissue, that reacts to the female's hormones. And they say that, or as we know, all breasts are different sizes. The size of the breast is pretty much governed by the amount of fatty tissue in the breasts, and some people may notice that when they put on weight or lose weight, the breasts do change in size, and that's because of the change in the fatty tissue in that area. Now this bottom area is just the passage of the milk. So when the female is what we call lactating, the milk starts out in the old alveoli and makes its way all the way up to the nipple. So that's just the passage or the process. The breast itself, we technically divide into 3 layers. So you've got sort of the superficial skin and fat layer, then you've got the middle mammary layer, which has that glandular tissue and all the functional tissue, and then at the back, mostly we've got the muscle again, and a little bit of fat back there. Now in the breast, to hold it all together and keep it all in shape, we have ligaments called Cooper's ligaments, and they're really just there to support the breast and hold the breast in a nice shape. And as we talked about earlier, both males and females can get breast cancer, so both males and females have breast tissue. What happens with females when they hit puberty, because of their changes in their hormones, and the affected hormones are estrogen and progesterone in the female, those 2 hormones in puberty increase in females, and it is that increase in those hormones in the female that cause the breast to develop more. Males don't have that estrogen and progesterone, and therefore their breasts don't develop at puberty like the females do, but males do still have breast tissue. Alright, so just on this diagram here, you can see what we're seeing is all the way back to the chest wall. So here's our, this is our muscle all the way back here. We're seeing the ribs, and then the lung will be in behind here. So often if you're really deep on your ultrasound, you'll actually see the lung as the person breathes moving. So we need to make sure when we're looking at the breast, we're scanning all the way down to this muscle layer. The yellow is the fat, and then the gaps in between, think of those as the Cooper's ligaments holding the structure. And here's our glandular tissue, our functional tissue that produces the milk. So we're out in the alveoli and the lobules, and then into the ducts coming up. All the ducts come up to the nipple for the baby to actually feed off at the nipple. Now, when we're looking and scanning breasts and looking at mammograms and ultrasounds, what we're looking at breast-wise and the tissue should match the patient's age. So what do I mean by this? Well, when we're younger, we haven't got as much fat in the breast, but we've got a lot more of that dense glandular functional tissue. Then if we think about a patient who has been through being pregnant and has maybe had the baby and now breastfeeding and therefore is lactating, the breasts are going to again be quite dense, and all of those ducts are going to be filled with milk, particularly if the baby is due to be fed. If the baby's just been fed, then the ducts won't be distended with the milk because the baby will have drunk the milk, and so the ducts need to fill up again. Once a female hits menopause, their hormones start going crazy, so their estrogen and progesterone levels change, and so the breasts change. And so that glandular tissue starts to disappear. They can become cystic, and they call it fibrocystic change because you get a lot of multiple little cysts. and the glandular tissue starts to disappear, and that we get more fatty tissue within the breast. So the breasts become fatty once you start hitting menopause, and once the female is over menopause and then is considered postmenopausal, the breasts are just about completely fatty, so they often lose their structure and they unfortunately start sagging down to our knees, which isn't much fun, but it's because of loss of that glandular functional tissue, the Cooper's ligaments, and just being fat basically sitting there, so they become a bit saggy and sorry. Now, thinking about this, we also then have to go, well, what about the females that go on hormone replacement therapy? So in those females, often they're given estrogen to top their estrogen levels up. So that is going to affect their breasts, and it's going to make their breasts look like younger breasts. So they won't have as much fatty tissue in them, and they'll be denser and glandular. And so often when we're looking at breasts and we're looking at change over time, sometimes what we're looking at won't match their age. And one time that can happen is in a menopausal, postmenopausal person who is actually on hormone replacement therapy. So getting information like that out of our patients is really important. So if our patient's coming for an ultrasound, there's nothing that they need to do or bring with them. If, however, they're having a mammogram and then coming for their ultrasound, often they'll be asked not to wear any talcum powder, deodorant or perfume. And the reason that we ask this is there are powders, deodorants and perfumes out there that actually have aluminium in them, so they have metal in them. And when you think we're looking for tiny little calcifications on the mammograms, well, these little bits of aluminium can mimic that. Now, they will be on the surface of the skin, but unless we're doing a tomo of the breast, then they're going to show up on our images. So generally speaking, as a preparation, if they're coming from a mammogram, they'll be asked not to wear these things. And so when you look tonight, go home and look at your perfumes or deodorants and just see if they say they have aluminium in them. The other big thing with breast imaging is previous films, and if you ever have a mammogram, family members have mammograms or ultrasounds, make sure they put them in a safe place so they remember where they are and they bring them with them for their next appointment. Because we always like to see the old films and we like to see how the breast has changed over time. That's very important. And often if we've had, say, multiple mammograms, we won't look at the previous one, we'll look at the one before that. So we actually go back a little bit further to look at the progress and how things have changed over time. So previous films, make sure they're in a safe spot and that you take them with you. So when they come for the ultrasound, if they're not already changed into a gown from a mammogram, which they probably will be, but if they're just for an ultrasound, we actually change them into a gown and we ask them to put the opening at the front. And this allows you to keep one side covered while you scan one breast, and then so they're half covered at any time. So in mammography, you'll often just take the gown off completely once they're in the room. It's just much easier. But with ultrasound, we can keep one side covered at a time. Now, the transducer we're going to use for ultrasound is our linear transducer. The breast is a very superficial structure, so we'll get away with the linear transducer, and 12 megahertz. So we don't need a lot of depth, however we want beautiful detail. So we'll use our 12 megahertz linear transducer to image the breast. Now, it's very important the setting up of our patient when we do our breast ultrasounds, because we need to make sure we're scanning and looking at all of the tissue. So the aim is that we roll the patient so that the breast covers their chest wall nice and evenly. So sort of roll them till you flatten the breast out on the chest wall nicely, and there's not bits of the breast tucked up under their armpit and things like that. So if it's the right breast, I'll roll them into a left posterior oblique position, and then what I'll do is I'll actually get them to stretch their right arm up above their head. So the rolling gets the breast tissue nice and even on the chest wall. The arm above the head then stretches the tissue so that it's not going to be mobile and move around on you, and you can make sure that you're scanning the entire breast. Obviously then when it's the left breast, we roll them the other way into a right posterior oblique position. Now to start scanning, I always scan the breast in two planes at 90 degrees to each other. So I go over the breast in transverse to start with, and then over the entire breast in longitudinal. But then when we're looking to image the breast, we actually consider the breast to be a clock with the nipple in the centre. So we will talk about 12 o'clock in the breast, 3 o'clock in the breast, 9 o'clock in the breast. So that again, this is something that's uniform throughout all sonographers. So we know exactly where lesions are within the breast, and then if the patient's coming back for follow-up in 6 months, and let's say I found a lesion at 2 o'clock, and now you're finding a lesion at 4 o'clock, well, that's not the same lesion as we were seeing at 2 o'clock. It is a new one or a different lesion. So it just is an easy, uniform way of looking at the breast. Now, how many pictures you take really does depend on where you work and what they like. Some places will want you to take a picture, a representative picture at every hour of the clock. Others will do it at a set number. So they might go, I want one at 12, 1, 3, 6, 7 and 11. And so once you've done your entire scan over the breast and check that there's nothing wrong, then you just document a few hours of the clock. We must also look at the nipple and take an image of the nipple, and also look up in the armpit or the axilla where the lymph nodes are. We're always going to see lymph nodes. What we're looking at is what they look like, whether they're enlarged, and their blood flow and things like that. So always look up in the axilla, because cancers are going to spread from the breast up into the axilla. So if I do find a mass or anything that looks abnormal, it's very important that I document it in two planes. So two planes at 90 degrees to each other, and as I said before, that I say exactly where it is at the breast. So for example, here we've got it at 2 o'clock, so we know where the lesion is, and then we let them know how far roughly from the nipple the lesion is. And these, you can get a ruler out if you want to, but usually you know the length of your transducer, so you can roughly work out whether it's, a centimetre from the nipple, 4 centimetres, 9 centimetres from the nipple. And this is just for follow-up purposes, so we can find these lesions when the patients come back. If we see any ducts at the nipple, we will measure them and see how dilated they are. And as I said, with the lymph nodes up in the armpit, we will see some. And if we measure them and look at the shape of them, and we can also put our coloured Doppler on and look at blood flow to them as well. Now I'm just going to skip over this slide to the next one to describe these things, but that's a description just there in words for you, but I want to look at it on an ultrasound image. So this is an image at the nipple. So we can see up here we've got the skin line and then some fatty tissue. Where we hit the nipple, you can see the roundness just here. So this here is all of the nipple, and then the black little things are just some ducts at the nipple. And it's fairly common in most people to see some ducts at the nipple. Now, our fat lobules are hypoechoic, so they're grayer. The functional glandular tissue is hyperechoic, or whiter, or echogenic. So the glandular tissue is white, the fatty lobule tissues are grey, are darker grey. Then in between you'll sort of notice there's some curly wiggly lines in between. They're the Cooper's ligaments in between, giving the support to the breast. And we're scanning all the way down to the bottom of the breast down here, and from here to here is actually the muscle. So all the way along there is the muscle, and then below that will be sort of ribs and chest. So we need to see from the muscle all the way up to the very top of the skin. Right, now these are what we would classify as benign appearances. So if I see a lesion in the breast and it has these characteristics, then we're going to go, this is probably a benign lesion, let's follow it up in 6 months' time and make sure it hasn't changed in shape, appearance or size. So a benign lesion is usually mobile, which doesn't mean, I had a patient once who said that, her lump moved from a right breast to a left breast. That can't happen, but if you push on it, you can usually move it around a little bit. So it's mobile, it's a little bit movable. When we're looking at with the ultrasound, we can see the borders of it really, really well. So it's well defined, we can see the outline of it, and those borders are nice and smooth, so they don't seem to stick out into the tissue. They're just nice, round, smooth borders. Generally, they're what we call wider rather than deeper. So they tend to grow with the tissue rather than against the tissue. And in a minute, I'll show you what that means. No tissue distortion means that they're not invading into the tissue around them. So the tissue around them doesn't look like it's being squashed, or there's no, say, fluid around to show that there's edema and the other tissues being affected. So if the tissue around just looks normal, then we're going to think the lesion's benign. If there's no posterior, if there's posterior enhancement behind the lesion, what this tells us is that that lesion is fluid filled, and therefore we're going to assume that it is a cyst. If a lesion is squishy and compressible, and we don't have to compress it all the way down, but if you can compress it a little bit, again, it's more likely to have some fluid in it and be all right, rather than a thick, dense mass that could be nasty. And avascular just means when we put our colour Doppler on that it doesn't have any blood flow within it. So anything with blood flow in it means that it could be vascular and growing. So if it's avascular, got no blood flow in it, that's again a benign symptom. So if when we're looking at our lesion, it has these type of characteristics, and it doesn't have to have all of them, but this is how we use these words to describe a lesion, then as I said, we're going to say it's likely to be a benign lesion. Let's follow it up in 6 months' time. Now, in comparison, we have our malignant list. So if we push on this little lump and it doesn't seem to be very mobile, it means it's invaded into the tissue around it, and therefore it's static, and so we can't move it a little bit. If it's disrupting the breast tissue, it means it's growing into the breast tissue around it, and therefore it's often referred to as spiculated. Now, spiculated I like to think of as octopus arms or rays of the sun. And they'll only be very fine, but this is the tumour growing out into its surrounding tissue. So it has an irregular shape, and you won't be able to see those nice smooth round borders. You might be able to in parts, but then in parts you lose it. That's not a good sign. So if it is invading, we can get the tissue around it reacting, we can get some edema and fluid around it. And these tend to be what we call deeper rather than wider. So they don't tend to grow with the tissue, they tend to grow against the tissue. If they have shadowing behind them, it means they have calcification with them. Calcification isn't always nasty, calcification, but there is calcification there, and big or small, so microcalcifications or larger calcifications, then we would want to put stick a needle in it just to make sure whether it is nasty or not. If it's got blood supply and quite good blood supply, then we worry that it could be malignant and growing. If we go up to the nodes, the lymph nodes up in the axilla, and they don't look normal, and we look like we've got nasty looking nodes up in the axilla, then you're going to be very suspicious of any lesion you find in the breast. Now, the nipple should always, well, in the majority of people, the nipple points outwards. Okay. In some people, they do have a retracted nipple, which means instead of pointing out, the nipple points back in towards the breast. Now that can happen, and people can have that from birth. So if you ever see a nipple that is retracted and pointing towards the breast, ask the patient if that's a new thing or whether they've had that all their life. If they've had that all their life, it's nothing to worry about. If it's a new thing, it's something to worry about, because what we're thinking is that there's a mass in the breast that is pulling the nipple back in and causing it to retract. And sometimes you can get, when you look at the skin of the breast, it can look dimpled, nearly like the dimpling on the skin of an orange. And again, that's a nasty sign, because that indicates that the dimple is the tumour pulling that skin back in. So they can be quite strong, these malignant tumours, and pull the nipple backwards. Alright, so let's look at some pathology now. Now, cysts, generally nothing to worry about. You can have one, you can have multiples, you can have little ones, you can have big ones. Sometimes we drain them because they become really big and they become painful and awkward, and obviously change the shape and size of the breast. So some poor people unfortunately do have to have these cysts drained, but generally speaking, they're nothing to worry about. Sometimes also you can get infections within cysts, and you can also get some bleeding, so like a little hemorrhage within the cysts as well. If we start seeing those things, we tend to worry a little bit more. So as what we call a simple cyst, we don't worry about, but if they start to become complex and have debris in them, then we will often suggest sticking a needle in them just to be sure. So any cysts in the breast should be nice and round. You should be able to see around the periphery of it nicely, so it's well defined. Should be fluid filled, therefore anechoic. If it's sort of bigger, you'll be able to see your posterior enhancement artifact in behind the cyst, which just lets you know that it's fluid filled. So generally speaking, they're nothing to worry about. So here's some images. I've just taken these off the website, and the website said yes, these are cysts, but let's look at them from our criteria. So if we take our first one just here, we can see around the periphery of it nicely. It's anechoic in the center. We've got our posterior enhancement in behind it, and it's got all those benign symptoms. If we look at this one here, again, we can follow around the outside. I can see the periphery of it all the way around nicely. It's anechoic and fluid filled because we've got our lovely posterior enhancement happening in behind it. Now this one also has the characteristic of being wider, okay, going with the breast tissue rather than deeper, going up and down. All right, it's growing wider with the breast tissue. So all of those are benign characteristics. So we would probably say both of these are cysts and recommend follow-up in 6 months' time. Fibroadenomas, you've probably heard this word, are very, very common. They're just usually made of normal breast tissue that has sort of proliferated and grown into a lump or a mass due to estrogen, and often the female's estrogen hormone may be a little bit higher or a bit erratic, causing these to form. They're benign, they're nothing to worry about. They can grow quite big and they can outgrow their blood supply when they get quite big, and then they can become cystic and a bit necrotic in the centre, and then we worry about them because they don't have all the benign characteristics. So often then they'll be going, I'm going to stick a needle in this, but generally it comes back as fine. It's just the fibroadenoma. So the patient can get them at any age. They can be lobulated, which means they can have some sort of bumps on them rather than just being smooth. However, if you look at the periphery, you'll be able to see around it nicely, be well defined. It won't look like it's invading. Generally, they'll be homogeneous within themselves, but they'll often be a little bit darker, so a little bit more hypoechoic to the surrounding fatty tissue. And they can have some posterior enhancement, particularly if they've got some fluid within them. Again, they will be go wider rather than deeper, and often we will say that we believe them to be fibroadenomas, recommend rescan in 6 months just to make sure that they haven't changed. And as I said, if they're looking a bit, we're not sure, we would definitely go straight to a biopsy just to confirm that that's what they are. Now again, these are fibroadenomas because the websites said that they were. But again, let's look at the characteristics of these. So we can see around the periphery nicely, it doesn't look like it's invading. It's wider rather than deeper. We can maybe make out a little bit of posterior enhancement coming there. And the same with this one. This one is a little bit lobulated, so we've got a bump there, and then it comes around and a little bump there. So it is a little bit lobulated. Again, it's wider rather than deeper, and we can see the periphery nicely. So both of these we would probably go fibroadenomas. Let's follow up in 6 months' time. Now, the bad thing about the cancer is there's lots of different types, but the most common one is the infiltrating ductal carcinoma. So these start in the ducts and then they invade or infiltrate out into the surrounding tissue from there. So just keep in mind that there are lots of different ones. And you can see with the papillary carcinoma, not a great percentage, but a common symptom that the patient will have is a bloody discharge from the nipple, which is why any discharge we tend to want people to talk to their doctor about. So again, let's go through. The websites have said these are all malignancies. So let's go through our characteristics with these. Now, this one has the characteristic of being wider rather than deeper, which is a benign characteristic. It has a calcification. If I look at the periphery, can you see it's not nice and smooth? And it looks like we might have like a little spiculation coming up here, growing into the tissue, and out here's one. Okay, and then it's growing down into here, down onto the muscle. So from that point of view, mainly because of the border of it and these spiculations, you'd want to stick a needle in it. So it has some benign and malignant. This one has a lot of shadowing. Okay, so shadowing is a malignant characteristic, and this has the spicules, okay, coming out, quite big ones. Spicules, tentacles, rays of the sun coming out from it. So that's what that looks like. They're quite large, and you can't define the border. Where does it start and stop? This one, that's a very nasty looking one, this one. Now this one here looks a little bit like a fibroadenoma. The white in it are the calcifications, but then when I go to the periphery, I can sort of make it out, but it's a bit ill-defined. It's smoother here, but a bit bumpy there, and there's maybe a spiculation there, and then you go, oh, is it growing out over here as well? So that's got some nasty characteristics. And this one nearly looks round like a cyst, but then we've got another bit growing off there, and another bit growing off there, and this other bit growing down here, and so that fits that we'd want to go, oh, I think we'll stick a needle in that. And so according to the websites, all of these were malignancies. So you can see sometimes they have characteristics of both benign and malignant. But if in doubt, I've always found the best option is let's biopsy it. Now, we've talked a little bit about males, and males can get breast cancer. Now, the thing about the males with the breast cancer is because the breast tissue isn't developed, it hasn't got all that tissue to invade and grow within. So they tend to be invade into the chest wall muscle and the chest wall very early on because there's nowhere else for them to grow. So from that point of view, they're often more aggressive. And also with males, you know, it's the last thing a male thinks of is that the male have breast cancer. A lot of people didn't even realise that males can get breast cancer, and so they often ignore a lump or a retroverted nipple or something like that for a lot longer. Now, the other thing that males can have is a condition called gynecomastia, and this is a lump they'll notice a lump has developed under their nipple in their breast. Sometimes they can even have some breast tissue development, and the lump that they're feeling will be very, very tender because it's the glandular tissue starting to develop on them, and it will be very sore. It's usually caused by a hormone imbalance, so it's often seen when their estrogen levels are very high, and they have this wrong hormone imbalance that's caused the breast tissue to actually start to grow and develop because it's sitting there. It should be dormant normally. The other thing you'll often see with particularly younger males with gynecomastia, often bodybuilders who take steroids. The steroids affects the breast tissue and cause the breast tissue to develop, and I find it rather interesting because they'll come in and they'll be, you know, have great physique and lovely muscles, and then they've got boobs, and it's just like, that so does not match. And when you see them, you just go, oh, you take steroids, don't you? And they go, yes. And it's the steroid taking, okay, beefs their muscles up, but also causes their breasts to develop. Now, what do we do about it? Well, if we can right the hormone, if it is the hormone imbalance, right the hormone imbalance, get the estrogen levels down to normal male estrogen. They only have a little bit of estrogen, males in the body. Then the breasts will calm down. If they're on the steroids and it's the steroids causing it, then they need to obviously get off the steroids, otherwise the breast tissue isn't going to change. Also, some medications can cause it as well, so some medications the patient might be on. So looking at your patient will tell you whether it's a steroid patient or just a hormone imbalance patient. But a lump and very tender, and I find most males that I do, young or old, will be rather embarrassed. Probably I find them more embarrassed than any female that I've ever had that's been embarrassed about being there and having their breasts scanned. So it is about making them feel very comfortable and letting them know that we do see a lot of males and they're not alone. So just to finish up this lecture, I just wanted to discuss, I suppose, the role of ultrasound in imaging the breast. So where does it fit? Why or when would we do an ultrasound? If we're doing a mammogram, why do we need an ultrasound, or why do we do an ultrasound and not a mammogram? So just remember that an ultrasound is really good if we've seen a lesion on a mammogram to determine whether it is a solid or a cystic lesion. Now, if it's a solid lesion, we're going to worry about it. If it's a cystic lesion and a cyst, we're not going to worry about it so much. It's very useful in the younger, denser breasts, in the lactating breasts, or the breasts of a person who's pregnant who we don't want to irradiate. Useful with palpable lumps. So as I said earlier, if we can feel a lump, put our finger on the lump, put the transducer on the lump, we know exactly what the patient's feeling. So that helps a lot in, rather than just going, oh, where is that lump that they're feeling on this mammogram image. So the young people, pregnant, lactating people, if they're uncertain on the mammogram, or there's something that on the mammogram they want to have a more in-detailed look at. So our biopsies, when they do hook wires, they can often see where the hook wire is going to go and place it in the right spot under ultrasound guidance. And also if we've got cysts and we want to aspirate them or take the fluid out of them, we can do that under ultrasound guidance as well. Now, the big thing about mammography, and particularly the screening mammography, is that we're trying to pick up cancers when they're in their smallest calcification stage, so that early and before they've spread. Now, modern ultrasound machines are starting to pick up these calcifications. They certainly are, but at this day and time, our ultrasound could not replace mammography as a screening tool for breast cancer. So mammography at this stage in technology remains the gold standard for detection, even though ultrasound has made great improvements in that area. But as a screening tool, I definitely, for now, ultrasound isn't about ready to replace mammography.